So trachea, see this part is larynx, below the level of cricoid cartilage or below the level of C6 vertebral level, here is the trachea. After this bifurcation into two principal bronchus, okay. So trachea is a wide, flexible and fibrocartilaginous tube which conveys the air from larynx to the lungs. Okay, so this is function of trachea. It has C-shaped cartilage. Number of cartilage is important. It is about 16 to 20 C-shaped cartilages are present in the trachea. Okay, number is important for your Viva and MCQ. And these rings keep the tracheal lumen open. Where is the location? Trachea is located in the lower part of neck and in the superior mediastinum. Okay. Mediastinum is done? Yes or no? Yes. So what is the extent of trachea? Trachea begins as continuation of larynx at the lower border of cricoid cartilage or lower border of C6 vertebra here. From here it begins. This vertebral level is important. Lower border of C6 vertebra or lower border of cricoid cartilage. Okay. And it divides into right and left principal bronchi at the level of lower border of T6 vertebra. T6 vertebra according to the 41st Grace. Okay, and previously it was believed that trachea bifurcates at the lower border of T4 vertebra, that is sternal angle level. Okay, but according to new concept, bifurcation occurs at the lower border of T6 vertebra. Okay, so this is the extent from C6 vertebral level to T6 or previous, according to previous concept, lower border of T4. Lower border of cricoid cartilage up to the tracheal bifurcation into two principal bronchus. And you can see the length of trachea is about 10 to 11 centimeter. Okay. So dimensions, length is 10 to 11 centimeter, external diameter is about 2 centimeter in males and 1.5 centimeter in the females. And internal diameter of the trachea is smaller in the living than in the cadaver. Okay, because in cadaver there is blood vessels are prominent, there will be secretions present in the lumen, and at 1 year of age, the lumen of trachea is about 3 millimeter, approximately 3 millimeter diameter. These are the relations of trachea. See, this is larynx, here is the trachea. On the two sides, you can see the two common carotid, right common carotid, left common carotid, and these are the vagus nerve, right vagus, left vagus, in the cervical region, okay. And here in the thoracic region, in the superior mediastinum, you can see anteriorly lying this arch of aorta and its three branches, brachiocephalic trunk, left common carotid, left subclavian, and this arch of aorta continues downward as the descending thoracic aorta. Here is the vagus nerve, left vagus. From here, one branch is winding on the undersurface of the arch of aorta, that is left recurrent laryngeal nerve. Okay, and these are the brachiocephalic veins, right and left brachiocephalic veins joining to form the superior vena cava, and here are the two internal jugular veins, and these are the subclavian vessels. Okay, so all these are related on the anterior aspect of the trachea, and here you can see the bifurcation of the pulmonary artery, and this is the esophagus. Esophagus is lying posteriorly. Okay, thoracic duct is also lying posteriorly, and here is the azygous vein which is draining into the superior vena cava. Okay, so we will discuss the relations now. So first, relations of thoracic part of trachea, anterior relation. Anteriorly lies, anterior most is the manubrium sterni. Okay, superior mediastinum. It is not present in the inferior mediastinum. At the lower margin of superior mediastinum, it is bifurcating. Okay, so anteriorly lies manubrium sterni. Then the left brachiocephalic vein, this one, left brachiocephalic vein. Here is the trachea. Left common carotid, this one is left common carotid. Arch of aorta, this is arch of aorta. Deep cardiac plexus. Branches from vagus nerve is forming some plexuses here. So that is known as deep cardiac plexus. And thymus gland, it is present in the children only. On posteriorly lies the esophagus. You can see here this muscular tube is the esophagus. Left recurrent laryngeal nerve, it is hooking on the undersurface of this arch of aorta and then lying posterior to the trachea in the tracheoesophageal groove. And the vertebral column posterior to the esophagus will be the vertebral column. Okay, so these are the posterior relation of trachea. Next, we are going on the right side. On the right side will be the right lung and right pleura, right vagus nerve and the azygous vein. Okay, this is here is the azygous vein. Here is the right vagus nerve. Right lung and pleura will be lying in this area. Okay. On the left side, there is arch of aorta here, arch of aorta, left common carotid, left subclavian vessels. These are the left subclavian vessels, left subclavian artery mainly, and left lung and pleura will be present. So, a schematic diagram like this you can practice. Arch of aorta along with its three branches from right to left is the brachiocephalic trunk, left common carotid, left subclavian. Okay, here lies the thyroid gland, just in front, below the larynx, in front of the trachea. Isthmus is lying. Okay, so tracheostomy is done. You have to identify the isthmus. You should not pierce the isthmus. Tracheostomy is done above the isthmus or below the isthmus. Okay. Tracheostomy is important life-saving procedure. A hole is made in the trachea and a tube is inserted for direct entry of air into the respiratory tract. Okay. And if needed, it is connected with the ventilator. Okay, and here is arch of aorta is continuing downward as the descending thoracic aorta. Here is the esophagus lying in posterior relation. And these are the laryngeal cartilage, thyroid cartilage, cricoid cartilage. Okay, and this is cricothyroid membrane. So trachea, this is histology in microscopic structure of the trachea. We have 4 layers here. So first is the mucosa. Mucosa consists of these 2 layers, lining epithelium and lamina propria. Lining epithelium consists of pseudostratified ciliated columnar epithelium with goblet cells, brush cells, small granule cells and basal cells. And lamina propria contains bronchus associated lymphoid tissue BALT separated from the submucosa by the elastic membrane. Okay. Then there is submucosa. Submucosa contains the connective tissue and mucous glands. And then there is cartilage and muscle. C-shaped hyaline cartilages are there and trachealis muscle, which consists of smooth muscle fibers. It is bridging the 2 ends of C-shaped cartilage. Okay, you have already seen histological sections of trachea. Next is Adventitia. Adventitia is the outermost fibroelastic tissue. Okay, and here basement membrane of trachea is very thick and bronchus BLT is bronchus associated lymphoid tissue. Okay, so these are the histology of trachea. You have already drawn trachea, histology of trachea? No, okay. So there will be histology class for section of trachea, it is important. So we have, it has 4 layers, mucosa, submucosa, cartilage and muscular layer, they are lying in the same plane, and outermost is adventitia. So mucosa has pseudostratified ciliated columnar epithelium and it has ciliated columnar cells with goblet cells. Goblet cells are mucus secreting. There are brush cells are sensory cells and small granule cells, these are enteroendocrine-like cells, and basal cells, these are germinal cells. Okay. And this epithelium rests on thick basement membrane and lamina propria that has bronchus associated lymphoid tissue, BALT. And trachea has 16 to 20 C-sepid hyaline cartilage. You will see the section of the cartilage in histology section. And gaps of tracheal rings are filled by fibroelastic tissue and trachealis muscle, which is a smooth muscle. You have seen during the section of hyaline cartilage histology, you have seen sections of trachea. Okay. Also during the epithelium, pseudostratified ciliated columnar epithelium, this is present in the trachea only. And externally it is covered by fibroelastic tissue of Adventitia. Okay. Next we are going to arterial supply, venous drainage, lymphatic drainage and nerve supply. Okay. So arterial supply is by inferior thyroid artery. You have seen location of thyroid gland, which is supplied by two superior and inferior thyroid arteries and drained by three veins, superior, middle and inferior thyroid veins. Okay. So arterial supply is from inferior thyroid arteries. Venous drainage is via left brachiocephalic vein. You have seen it is crossing just over the trachea. And lymphatic drainage, lymphatics are draining into peritracheal, pre and paratracheal lymph nodes. Okay. And nerve supply of trachea is autonomic supply is there, no somatic supply. Autonomic supply means there will be parasympathetic nerves and sympathetic nerve. Parasympathetic nerves come from vagus and recurrent laryngeal nerve, which are branch of vagus. Okay, so mainly from vagus, and these are sensory and secretomotor to the mucous membrane and motor to the trachealis muscle. And sympathetic nerves, they comes from middle cervical ganglion. Sympathetic chain, you have seen location of sympathetic chain. So sympathetic nerves are coming from middle cervical sympathetic ganglion along the inferior thyroid artery, and they are vasomotor. They control the function of vessels. Okay, constriction and dilatation of the vessels. So these are the nerve supply. Next, we are going to clinical aspects. Clinical aspect comes in your explain why question, okay, or part of the long question. So, clinical aspect, palpation of trachea. You have to learn how to palpate. With 3 fingers, we palpate it in the suprasternal notch. Middle finger is placed in the suprasternal notch, and on the 2 sides, we place these 2 fingers. If trachea is deflected to one side, it will be felt more on the sides to which it belongs. Okay, right side tilt hoye thakle, right finger will feel the trachea more, and left finger will not feel the trachea. Like this, you have to know the position of the trachea. Okay, you have to practice it during the clinics. You will learn from the second year. So palpation is done in suprasternal notch, and trachea lies in the median position generally. Next is tracheostomy. Tracheostomy, very important procedure. It is a surgical procedure. You have to read it as a short note during your final year. Okay, tracheostomy. At which level you will do, how it is a surgical, what will be the incision, vertical incision or horizontal incision, and other things you have to know. So, tracheostomy is a surgical procedure to create an opening in the neck to allow direct entry of air into the trachea. Here, you can see here one opening has been made. This part is larynx. Below the larynx, here is the trachea. So, one opening is made in the trachea, and tracheostomy tube is inserted. There is a balloon which keeps the tube patent, and there is a direct entry from outside into the respiratory tract through this opening of the tracheostomy tube. Next, there is carina. What is carina? This term is important, asked in your viva. So, the median ridge in the trachea at the bifurcation of trachea is known as carina. This is important during your bronchoscopy. Okay, after the carina, you have to enter the bronchoscopy tube into the one of the principal bronchus. Okay, then you have to reach up to the pathological location. And this it is richly supplied by sensory nerves and can induce cough reflex. That's why you have to prevent touching the carina during the bronchoscopy. This is tracheostomy is shown in enlarged view. Here is the larynx. Below this is thyroid cartilage. Here is the cricoid cartilage. Below it, here is the from here trachea. And this is the balloon of the tracheostomy tube. Here is the opening. And see, this is the carina. Here trachea is bifurcating. This is bronchoscopic view. Okay, bronchos from above we are seeing. And these are the two principal bronchus, left and right principal bronchus. This is schematic diagram. Here is the carina, this ridge-like structure, and on the two sides two bronchi, left and right principal bronchus. And you can see in the trachea there are C-shaped cartilaginous ring, and the two ends of the rings are bridged by this muscle that is known as trachealis muscle. This mucus secretion. Mucus glands of the trachea secrete mucus which help to capture the particulate matter from the inhaled air. And cilia of the tracheal epithelium beats upward and expels the mucus from the trachealis muscle maintain the diameter of the trachea. And how we will see the tracheal shadow in the radiograph. See the black shadow overlapping the spine of the vertebra. This is tracheal shadow. Okay. The tracheal air produces shadow in front of cervicothoracic spines in the radiograph in this region. Okay, in the upper thorax only you will see. So this is tracheal shadow. Here you can see this part, the black shadow, black tube like shadow, that is tracheal shadow. And these are the shadows of the spines of the thoracic and cervical vertebrae. Okay, understood? Tomorrow is radiology of thorax. Okay, tomorrow. So you will see the X-ray plate of chest X-ray. Okay, so these are the clavicle, ribs. Okay, mediastinal structures we will discuss tomorrow. So next is endotracheal intubation. Okay, so endotracheal tube should be selected according to the age of the individual up to the age of 12 years, because luminal diameter increases by 1 millimeter per year up to the 12 years. Okay, so you have read during 1 year of age it is about 3 millimeter. After that it is gradually increasing. So according to the size you have to choose the size of the tube, tracheostomy tube. Okay, or intubation tube, endotracheal intubation. Endotracheal intubation is done through the mouth. Okay, you have already seen during general anesthesia endotracheal intubation is done. Okay, here you can see this endotracheal tube have been introduced through the mouth. Here are the upper lip, lower lip, oral cavity, oropharynx, laryngopharynx. After that it is entering through the laryngeal opening into the larynx, into the trachea. After that air can pass into the lungs. Okay, bronchus and the lungs. And during tracheostomy you are making a opening here in front of the neck. Okay, that is the difference between tracheostomy and endotracheal intubation. In tracheostomy is done when the upper airway blockage is present, and endotracheal intubation is done during some kind of lung pathology or during general anesthesia like this. Okay. So these are the relations we have discussed. Trachea in front of the larynx and trachea. This is thyroid gland. On the two sides, the common carotid artery, vagus nerve. These are the internal jugular vein and subclavian vein joining to form the brachiocephalic vein. Left brachiocephalic vein is length is more, crossing the trachea in front and joining two brachiocephalic vein forming the superior vena cava. This is arch of aorta. This is left vagus is giving recurrent laryngeal nerve. These are the three branches of the arch of aorta: brachiocephalic trunk, left common carotid, left subclavian. Mediastinal structures, all these structures you have seen. You have to identify, all these are important for your OSCE. You have to identify the structure and related questions will be asked. Okay. And here is descending thoracic aorta, esophagus, thoracic duct, azygous vein draining into superior vena cava. This is bifurcation of the pulmonary trunk, and these are the pulmonary veins. Okay, understood all these structures you have seen. Okay, that's all. Any query from this topic? Bronchus and further divisions we have already discussed, okay, during the bronchopulmonary segments. So you have to differentiate, you have to be able to differentiate the section of trachea, histology section of trachea and bronchus. All these are asked in your viva and theory also, okay. And the clinical aspects are important for your explain why or part of the long question. Any further queries? You prepare trachea as a short note, okay. Any further queries? Palpation you have to learn during the clinics. With these three fingers you have to palpate. Middle finger you place in the suprasternal notch, okay, just above the manubrium sternum, and on the two fingers are placed on the two sides. If trachea is in the median plane, these two fingers slightly touching the trachea on the two sides, okay. And if trachea is displaced, okay, you feel this is trachea, okay, you are placing it like this. In the middle, you can feel the trachea. On the two sides, you will touch the two lateral aspects of the trachea. If it is displaced, so middle finger will be here, and on the right side, you will feel it more, and on the left side, it will not feel the trachea. That's how you determine on which side it is displaced. Okay. And you have to do it very carefully because chance of cuff reflex is very prominent, okay? To press করলে দেখ cuff আসছে